Hi, I'm Steph Garbern. I'm one of the faculty in the Division of Global Emergency Medicine at Brown University. It's a great pleasure to be invited to give this presentation on emergency medicine in resource-limited international settings. My goal is to provide an overview of the fundamentals of global EM for primarily North American-based EM residents who are planning to work clinically or on educational collaborations abroad and outside of high-resourced clinical settings. We'll get started by reviewing the state of emergency medicine as a formal specialty globally, then discuss some key competencies you'll need in order to provide effective and high quality emergency care in resource limited settings. Then we'll dive into some hacks or strategies that are great to have in your toolbox for common EM procedures when working with fewer resources than you may be used to at your home institution. Lastly, we'll discuss some general tips for working abroad effectively as an EM doc. And before we get started, I just want to acknowledge my perspective as someone who has had access to formal EM training and works primarily in a high income country academic institution, but that there are many other perspectives and lessons to be learned from those who may not have had the same access to training or resources. But that is what makes global EM so exciting and collaborative. I hope that I can share some of my perspectives as well as those from colleagues working outside of the US as well. So, where is emergency medicine globally? Turns out that question is a bit harder to answer than you might think. Here is a map created by the International EM Education Project in 2019, which shows where EM is recognized as a specialty. Darker red shades indicate earlier years since the specialty was recognized. For background, EM was developed initially in the UK and US in the late 60s, early 70s, then Canada, Australia in the 70s and 80s. As of today, there are over 80 countries where EM is formally recognized, although this is still well below half of the world's 200 or so countries. Here we can see that there are large regions of the world where EM is simply not recognized or in a very early stage of development, particularly in Asia, Africa, as well as parts of Europe. But what this map doesn't really show is that even when there is formal recognition or training, EM may only exist at a single institution in a country with a strong bias towards urban settings. For people who have trained in countries where EM is well established, we can hopefully share some of the knowledge gained from the history of EM specialty development. And there is a great need to teach emergency medicine as a specialty and as this specialty continues to evolve throughout the world. Another resource I want to point you towards is another map created by the ACEP International section, which collates data from the annual country reports completed by ACEP International ambassadors, who help promote the growth of EM as a specialty around the world. While the list on this map is far from being complete, the list continues to evolve and is a great resource to see where there are training programs, EM professional societies, and EMS systems to find potential projects and collaborators. And there's a great article by Andres Patino and colleagues describing the status of EM globally that is included as a reference at the end of this presentation. It's important to remember that even if EM isn't formally recognized, that does not at all mean that emergency care isn't being provided. Emergency care is almost always being provided, although often not under the banner of EM, and it may be delivered in a different way than you might be used to or by different people than you are used to. In places where EM is not formally recognized yet, emergency care is usually provided by physicians, such as those from the medical or surgical specialties, or by non-physicians, such as clinical or medical officers, nurses, community healthcare workers, or EMS workers. Next, we'll review some key competencies when working in resource-limited settings abroad. There are several major areas of global EM work that you might get involved with. I'll focus on these first two as these are the most common areas that residents would be involved with. Emergency medicine development focuses on the development of the specialty of EM globally, both at the health systems and individual training level. You might be involved with establishing pre-hospital care systems, triage or trauma care systems, the creation or development of emergency departments, and or the training of emergency medicine providers. Delivery of acute care includes the diagnosis management of patients with acute presentations of various illnesses and injuries, particularly focusing on optimizing the use of resources available. Disaster and humanitarian response requires its own specialized set of skills, and from an ethical standpoint, it is rare that a trainee would be deploying to an international disaster. So I won't go into this during this presentation, but know that there are lots of resources for gaining the specific skills needed to be effective during a disaster or humanitarian crisis. The great part about emergency medicine is that you are constantly treating patients with a wide variety of illness. So, a lot of the time, you can adapt what you already know and use your skills to fit the context you're working in. For example, when performing procedural sedation in a resource limited setting, you might not have a lot of options or medications for sedation, but often you might have ketamine, which you'll be familiar with from home, and you'll see it used fairly commonly for indications you might not expect, such as to sedate ventilated patients. I've listed here some priority skills or topics that are fundamental for practicing EM globally, and this is not comprehensive, but I hope it can give you a start. First, it's really important to have a strong understanding of triage systems and have the ability to independently triage patients into different risk categories. Often, triage isn't a large part of our residency training in the US, but learning basic triage concepts will help you adapt them to whatever clinical environment you work in. And developing triage systems is one of the highest priority needs for many hospitals during their development of emergency departments. So before you go abroad, make sure that you learn what systems, if any, of triage are used where you're going, and learn about triage in resource limited settings in general. And one common system that is great to learn about is the South African triage system, which is used in many countries, particularly in sub-Saharan Africa. Additionally, hone your ability to resuscitate patients and manage trauma patients without relying on advanced technology or resources, particularly advanced imaging. A lot of what you do when you manage critically ill patients in resource limited settings will involve constant reassessment of patients using your physical exam skills and making rapid decisions when working with limited access to diagnostics like laboratory tests and imaging, even more so than we already do in our usual practice in the ER. And there are some areas that you will very likely not have sufficient exposure during a typical US residency, such as managing neonatal and maternal emergencies like complicated deliveries, postpartum hemorrhage, postpartum cardiomyopathy, neonatal sepsis, congenital heart disease. And you'll need to have these skills much more frequently outside the US because the morbidity and mortality from perinatal conditions and in early childhood is much, much higher in places with poor infrastructure and healthcare access. Managing acute presentations of infectious diseases will also constitute a large part of what you will do as an EM provider. The epidemiology of what exact infectious diseases you might see will vary greatly depending on the population. So make sure to understand the context of where you are planning to work first. However, diseases such as HIV, tuberculosis, vector-borne diseases like malaria or dengue, parasitic diseases which can have acute presentations like schistosomiasis, and vaccine preventable diseases like meningitis, tetanus, and hepatitis are much more commonly encountered in low and middle income countries. It can be difficult to gain the sufficient amount of expertise with diagnosing and managing these diseases while doing your training in the US. So it's worth considering additional training, perhaps with a diploma in tropical medicine and hygiene, as this will give you a great foundation for common tropical diseases. Patients with non-communicable diseases will also often present at much more advanced stages of illness than what you might be used to seeing in higher resourced countries. While NCDs are common and on the rise everywhere, it can be surprising to see many relatively young patients in their 20s, 30s, 40s presenting with very advanced cardiac disease or complications from untreated hypertension or diabetes without possibly ever having had a prior diagnosis or knowledge of this, as they might not have had access to primary care, or if they perhaps did have a diagnosis, they might not have had access to care or medications to control chronic diseases. Lastly, palliative care and end of life care are rarely formally available in resource limited settings, but this is an area where our expertise as ER doctors in managing acute pain and alleviating suffering during end of life situations can be extremely valuable skills to bring to places that don't have access to these specialties. And these challenges of clinical work multiply exponentially when you have little infrastructure, staff, and other resources. So just try to focus as much as you can during residency on gaining additional physical exam skills and procedural skills, and seek additional training when needed. I've also listed some courses that are great to get certifications in prior to working abroad. As mentioned, a DTMNH course is great for clinical infectious diseases. And then becoming a trainer for internationally recognized courses like the WHO Emergency Triage Assessment and Treatment, ETAT for triage of pediatric patients, and the WHO Basic Emergency Care course, as well as courses like Stop the Bleed, BLS, ATLS, and PALS. This is far from being a comprehensive list, but here are some essential EM procedural skills for resource limited settings. Many of these skills you'll already be familiar with, but make sure you know how to perform these procedures using a wide variety of equipment and be able to perform these without specialist access. One of the most important skills is being very confident with peripheral vascular access, since central lines are very rarely used or available, even for indications such as vasopressor administration. Becoming highly competent in many techniques for peripheral access is very important. I highly recommend taking time to learn from your pediatric ED and ICU nurse colleagues to gain practice and skills with placing IVs in unusual locations and in small patients. For instance, you might not have a lot of experience using scalp or umbilical veins or feet for vascular access, but it'll pay off to gain these skills and get some practice with pediatric patients because these will constitute a large proportion of the patients that you'll be treating. And in this picture here, this is a useful technique using just a simple rubber band as a tourniquet for an infant for scalp IV placement. This was definitely something I had never done before prior to working outside the US, but it is really useful when you have an infant or child with severe dehydration or sepsis, and this might be the fastest and best chance for vascular access. Other common procedures include thoracentesis, paracentesis, which should be common from your current residency, but you may need to get creative with the supplies used to perform these procedures. And then other procedures like pericardiocentesis are much less common in the US, but in many low and middle income countries, particularly where there are high rates of HIV and TB, you'll be seeing pericardial effusions much more commonly. And in fact, tuberculosis is the leading cause of pericardial effusion in low and middle income countries. And it's just a procedure we don't do very often in emergency departments in the US. And some other skills that we do, but we need to have more practice with or be able to perform more independently, like complex fracture care or direct laryngoscopy, that we just don't do often enough because we have access to other tools like video laryngoscopy or handy orthopedic consultants. So gaining additional experience with these really pays off. One key skill is being able to independently set up and adjust a ventilator if you're going to be working in an area where you do have access to critical care and mechanical ventilators and ability to intubate patients. Make sure you're able to do this without relying on a respiratory therapist. If you can't do this, then you really shouldn't be intubating or putting anyone on a ventilator yourself. And then there are some skills that are less common but very useful, like regional nerve blocks. And we're doing this more now, but as access to analgesics, particularly opioids, can be extremely limited, nerve blocks and regional anesthesia can be really important for managing pain. And then, while very rare here, burr holes may be one of your only options for serious head trauma, intracranial evacuations in some settings, but you should make sure you get supervised experience with these before trying to perform this independently. Finally, point of care ultrasound is extremely useful and in high demand in global EM projects. Many projects working to develop emergency medicine as a specialty include a large focus on providing new EM providers with point of care ultrasound skills, as ultrasound will often be the only imaging modality available to those providers in many resource limited settings. Key skills to become proficient in include fast, rush exams, cardiac and pulmonary ultrasounds to guide emergency department management. And then there are also some additional ultrasound skills that are not a large focus during most emergency medicine residencies in the US. For instance, specialized ultrasound protocols like the FASH or focused assessment with sonography for HIV and TB. This is really useful in places with a high HIV and TB prevalence. And additionally, in many clinical settings, you'll need to be much more comfortable with scans like routine obstetric ultrasound, especially with dating scans and evaluation of perinatal complications. Similarly, try to get experience performing ultrasound on pediatric patients during your residency, as you'll often be practicing in an emergency department without a dedicated pediatric ward or pediatric specialists, and those children will make up a large proportion of the patients you might see. And then lastly, ocular ultrasound is very useful in the US, but is particularly useful when you lack CT imaging for conditions causing elevated intracranial pressure, and also for ocular emergencies when you have very little access to ophthalmologists.
Now we'll go over some global EM skills or hacks that I hope you'll find useful. So this first one is really widely used and very easy, the Coca-Cola bottle spacer. So you can use any 500 ml plastic beverage bottle and create a hole cutout for a metered dose inhaler to deliver inhaled medications just as you would a conventional spacer, which costs much, much more. And these have actually been shown to be just as effective as regular spacers. And this is a really easy to use technique for when you want to be able to give inhaled medications, such as for your ED patients with asthma or COPD. It's really easy to do. Take a clean bottle and either cut out a hole the size of the MDI inhaler or use a heated wire by taking something like uh, a clothes hanger and bending it into a circle, and you can either heat it over a stove or a flame and use that to just melt a hole in the bottom and insert the inhaler. And a handy tip is that you can use a face mask, such as for a young child, as depicted in the bottom picture. And this actually fits perfectly onto the bottle opening of most soda bottles. Next is bubble CPAP, or what is called shampoo bottle bubble CPAP for low resource settings. So it's called shampoo bottle because this was the idea of Dr. Chisti, who's actually one of my colleagues in Bangladesh, who came up with this idea after seeing a shampoo bottle after a shift where multiple children he had been taking care of had died. And he'd gotten this idea that bubble CPAP, which is used in lots of high resource pediatric ICUs, could be created for a very low cost to help children with respiratory failure. Bubble CPAP, for anyone who has not spent much time in the pediatric ICU yet, is a form of non-invasive respiratory support, especially used for neonates, infants, and increasingly for children and even adults now which can be used as a bridge between oxygen therapy and invasive ventilation. And in the last few years, there have been other alterations or adaptations of these devices, and there are several ongoing clinical trials to better understand how bubble CPAP can be used for both pediatric and adult patients in low resource settings. And the idea of bubble CPAP is that PEEP can be generated through the use of an expiratory limb to a tube submerged in water. And all it requires is just an oxygen source, such as a concentrator or a cylinder, plastic bottle with clean water or an IV bottle, and a nasal cannula with prongs and tubing and a three-way stopcock. And these cost just a few dollars in comparison to thousands of dollars for traditional CPAP that you might see in a PICU in the United States. And in the next slide, I'll show a video showing one method of creating these systems.
This is technique 2 for making of indigenous bubble CPAP. For this we require one nasal prong, one IV set and three-way stopcock and IV bottle. First of all, take nasal prong and cut the common end of nasal prong. Now attach both cut end to the three-way, like this. The third end of the three-way is attached with IV set. And this other end of the IV set is submerged into the IV bottle. Now this IV bottle needs to be filled with 10 cm of water, and the pressure will be correspond to the deep end or submerged end of the IV set. For example, if we submerge this IV set up to 4 cm, the PEEP delivered will be 4. And this needs to be kept below the neonatal level, and this is the patient inlet, and this will be go to the oxygen source. So this is the complete circuit.
Next, we'll go over creating a very useful vasopressor infusion. Actually, this is useful anywhere, including in higher resource settings when you need a vasopressor drip very quickly. In low resource settings, vasopressors are often unavailable. However, shock is extremely common from many causes, including sepsis, hemorrhagic causes, etc. However, adrenaline is very commonly available, even in very low resource sub-district or district hospitals. So if you really need a vasopressor and your patient might have a reversible cause of shock, this can be a great method, although it's still more of a temporizing measure. You just take a single 1 milligram ampular vial of adrenaline, dilute this, just empty it into a liter of saline, and you can run this wide open with an 18 gauge IV with a microchip chamber. You get 20 to 30 micrograms per minute infusion of epi. One important skill to have is to be able to calculate and set up a gravity infusion. You'll rarely have access to an IV pump, so infusions will need to be calculated using drops per minute or by eye. Note that this means that gravity infusion rates are somewhat approximate. And I recommend reaching out to your nursing colleagues to get practice with this, as they'll have a lot more experience doing this than most physicians do. You can use the formula here to calculate how fast your drops should be falling in the chamber. However, there are also great apps like the IV drip rate app that you can download so you can visually match up the rate with the one on the app and set up a pretty good continuous infusion.
Once you've set up your infusion, you can then titrate the drip, looking at the drip chamber to match the rate that you just calculated.
Next, I'll show a few clips of some great hacks from colleagues Dr. Pascal Mugemangango in Rwanda, Dr. Simon Tumusime in Uganda, and Dr. Yassine Omer in Sudan. And this is coming from a great presentation at SAEM a few years ago.
Hello, everyone. My name is Dr. Pascal from University of Rwanda. I'll be talking about how to make a tube from energy tube. Normally, we have a tube which is expensive, and it looks like this. On this usually out of this normal chest tube because of too many trauma patients. I'm going to show you how to make a simple chest tube from energy tube. Before we start, let us first identify materials to be used. So here we have simple energy tube number 18, of course, which is big to use. We have scissor or surgical blade and other materials needed in chest tube placement, like gloves, suture, cleaning solution, anesthesia, and dressing kit. I will now show you how to make a chest tube from energy tube. Step one, we take this our energy tube, we remove it from the cover. Step two, we see from the top, we have some holes, which are few. So we need to add the more to make it a chest tube. So from the top, we add the more holes using our scissor or surgical blade. So now our chest tube is ready to use. So we use it, we place it in other materials, then we start our procedure of chest tube placement. Thank you. So I hope you learned a lot about how to make this simple chest tube from energy tube. Next, we have Dr. Simon, who will be talking about the splitting of oxygen from one source. Thank you so much.
Hello, everyone. My name is Dr. Simon Tumsima from Uganda, and I'd like to take you through this part on how to split oxygen from a single source. So, with knowledge of all this, let's go ahead and talk about how do you split oxygen from a single source. So with me here, I have the equipment that you need to be able to perform this particular hack. I have a simple regular stethoscope, which looks like this. I have nasal prongs. I have a simple oxygen mask. You can choose to use 2 oxygen masks or 2 nasal prongs, whatever you want to use. So let's go ahead and perform the hack. So the first step is get your simple regular stethoscope, take out the chest piece, take out the 2 earpieces, connect the stethoscope to the oxygen source by the stem, turn on the oxygen source, connect the nasal prong separately to and the oxygen mask separately to each ear tubing. And there you shared your oxygen. So thank you for watching this. I hope you liked our presentation. I hope you learned something. Please go ahead and share it with your colleagues. About the articles I've shared about, you can check them out in the reference section. Thank you so much.
Okay, so for our second hack, what we do is we use cotton balls to make ECG electrodes. And how we do that is we just get a simple cotton, cut it up into small pieces, dip it in water and almost daily, whatever you choose it to be. And once you have 3 of them ready, you will attach one of them into each one of the electrodes. So once you've connected all 3 of them, you need to make sure that the cotton is actually coming out. So when you attach it to the patient, you attach to the patient like so, and then you just use it as a fast and stick it to our patient. And now you can just watch the ECG for a reading.
Now we'll go over condom uterine balloon tamponade. So this is a low-cost version of a Bakri balloon, which is a device used in high-resource settings to manage uterine atony causing postpartum hemorrhage. And postpartum hemorrhage is the leading cause of maternal mortality around the world. However, these Bakri devices are very expensive, but a low-cost version can be created with a condom, Foley catheter, 60 ml syringe, suture material, and a clamp or hemostat. And the idea is that you can place the Foley into the condom, tie this off, and fill up the condom with saline, and then tamponade the uterus from the inside. And this can act as a temporizing measure, for example, to transport a woman with hemorrhage to more definitive care. And I'll have some videos. There are several techniques for how to perform this that I'll put in the references of this presentation. And here are some other substitutes for common procedural supply limitations. As mentioned, you can use an NG tube or even a Foley catheter for tube thoracostomy, central line kits for pericardiocentesis. You can use a rolled up magazine for fracture splinting, conventional needles instead of spinal needles for lumbar puncture. These are all very common, and there are many other methods for substituting supplies that might not be available. And some general tips for work abroad as an EM doc. Many of you have had prior experience working global health, often as an undergraduate or medical student, but what may be new is that now you'll be coming as an EM physician. Namely, you'll be representing the specialty of emergency medicine, and you might often be the only EM specialist in a country, so people will often look to you as the expert, even when you feel you might not be an expert at all. So a lot of your role when you work as an EM physician abroad is by modeling how EM clinicians think, providing insights from the knowledge gained over the years from places where EM has grown so far, particularly with regard to setting up systems of triage, critical care, and trauma care, and learning to collaborate with colleagues to leverage the existing strengths of a health system to improve patient outcomes using some fundamental principles of EM. And some last tips. First, it's indispensable to have your personal network of consults when you're abroad. Become friends with your colleagues from other specialties. During rotations, find friends who are like-minded, who have interests in global health, and create your network. You never know when you're going to need to bounce some ideas off your friend from pediatrics, when you have a 34-weeker preemie with congenital heart disease, or you need some advice on repairing a complex facial injury from a friend in plastic surgery. Make sure that you're self-sufficient for most procedures and that you can set up equipment for procedures and get supplies yourself. And importantly, know when not to do procedures. And then this one's hard, but become comfortable with diagnostic uncertainty, even more so than we already need to do on a daily basis, because you have even fewer resources such as labs, diagnostic imaging, or consultants. And then lastly, know when to say no if there's something that's not appropriate for you to do, like performing a procedure where you don't have adequate supervision, and know that it's okay to say that you don't know. So I hope that was helpful for you in gaining some ideas of some fundamental skills and strategies for practicing abroad as an EM physician. I have some references, including the maps of global EM development, some really useful clinical references and handbooks, some resources on global health in general and global health equity, and links to videos for hacks and procedures, including the ones that I included in this presentation. Thank you very much, and feel free to contact me with any questions at the email listed here.